Hello, I'm Dr. Kathleen Digre, and I am a professor of neurology and ophthalmology at the University of Utah. And I'm very excited to talk about headaches in older individuals. Answering the question, is age important? I'm going to be covering primary headaches that occur in older individuals. But interestingly, migraine does get better with age in many people. However, there are many secondary headaches due to something else that are increased as people get older, and some of these are very dangerous. Some headaches really only occur in people who get older. And then treatment of headache is tricky for treating people who are older because many medical problems can get in the way. Medications work differently, and I'm going to be talking about that. And then side effects from medications can be present. And this can be a problem as people get older. So when we diagnose headache, we divide things into primary headache disorders, which are the more common type of headache disorder, and secondary headache disorders. So you can see in this pie chart, all the red, those are primary headache disorders, like migraine with and without aura, tension type headache, short-lasting headaches like cluster or paroxysmal hemicrania or hemicrania continua, and then rare causes. And then there are secondary headaches. Unfortunately, these are very rare, but important to diagnose. And this can be caused from brain tumor, something vascular in the brain, subarachnoid hemorrhage, intracranial pressure being high or low, giant cell arteritis, and cervical spine disease. So I'm going to first start with migraine. And migraine is a headache associated with light and sound sensitivity, nausea and or vomiting, and it worsens with activity, and it's moderate to severe. Interestingly, if you look at this graph, you can see the blue, actually the blue is female, and then the red is male. And you can see that the peak age for having migraine is really in the 30s, late 20s, 30s, 40s, 45, 50. And then after that, it like starts to taper off. And so when people are older, let's say over 65 or 70, headaches are less common. So it gets less frequent. Migraine gets less frequent with age. Now, sometimes it doesn't. And that we'll talk about what we can do about that, but sometimes it doesn't get better with age and it can continue on. But for many people, it does get better with age. Now, when we think about treatment of migraine in older individuals, we first have to think about their underlying conditions because many people, as they get older, have heart disease or uncontrolled hypertension, or they have had a risk of bleeding stomach ulcers or something like that. So then I'm going to divide treatment into acute therapy for individuals who are older and then preventive therapy. And first, talking about acute therapy, many times we use things like ibuprofen, naproxen, but these carry a risk of GI hemorrhage. And in an older person who might have stomach issues, this can be a problem. Aspirin can be a treatment also for migraine with aura, for example, and also migraine. But again, the gastrointestinal problems can occur. Triptans are migraine-specific acute therapy, but they do have a little vasoconstriction as a side effect. So if a person who is older has underlying cardiovascular problems like coronary artery disease, uncontrolled hypertension, angina, and other kinds of cardiac issues, you can't use triptans. However, lasmiditan is a cousin to triptans, but it does not constrict blood vessels. So sometimes we do use that in older individuals, but it can cause sleepiness. Some of the new medications, the gepants, ubrogepant, rimegepant, zavegepant, are used for acute treatment of migraine. And most of the time, these are very safe and have very low side effect profile. Sometimes we have to look for pre-existing liver disease. I'm going to mention devices because if a person does not have a pacemaker, some of the devices that we have are really appropriate as people get older and if they have side effects from acute medications. Often we use antiemetics like metoclopramide, promethazine, and sometimes these medications can cause more side effects in older individuals. So these are some of the devices we have. I'm showing you first kind of the electrical devices. First, up at the top here, you can see the superior supraorbital nerve stimulator, sometimes called the Cephally device. And this device it has a little electrical pulse, and you can use it acutely and also preventatively. The transmagnetic stimulator is applied to the back of the head, and you can press that a couple times at the onset of a migraine, so it's an acute treatment for migraine. The vagal nerve stimulator is also an acute and preventive treatment. And recently, the supraorbital and occipital nerve stimulator, which has been added, is also a preventative and acute treatment. The transcutaneous nerve stimulator is mainly an acute treatment, but it is a stimulator that's placed on the arm and delivers a little stimulus, and sometimes can break up the headache. Now, there's some non-electrical devices as well. For example, the ice hat or various ice hats. Some people have found that the LA lamp or the green light therapy can be helpful for prevention of migraine. And many of us prescribe for our patients who have a lot of photophobia or light sensitivity, the FL41 tint. I'm going to switch gears now to prevention of migraine in older individuals. And here, the CGRP monoclonal antibodies can be first line in older adults. You sometimes have to use caution with if they have hypertension, constipation, because sometimes they do cause constipation. These medications are erinumab, galcanezumab, fremanezumab, and these three are given as once-a-month shots, and eptimizumab is every 3 months an IV infusion. There are a couple G-PANTs also as preventatives. Rimegepant can be used every other day, and atogepant is a daily G-PANT for the prevention of migraine. We have many old standbys in preventing migraine that can be used in older adults, such as beta blockers. Frequently, these are used in individuals who have hypertension. Angiotensin converting enzyme inhibitors. Examples are candesartan, lisinopril type of drugs, and these are often used in individuals who have hypertension and are older. So these are quite safe in older people. Memantine is often used, or Namenda is used for memory disorders, but it has been shown to be helpful for migraine. It is well tolerated in older individuals. Tricyclic antidepressants we've used for many, many, many years, and these are like amitriptyline, nortriptyline, but we avoid these as people get older because it may have an effect on memory and urinary retention. We do prescribe antidepressants like venlafaxine, duloxetine, and others, but again, we try to start low and go slow. Sometimes we use anticonvulsants, but they can have a lot of side effects in older individuals, so we sometimes have to be careful. Onabotulinum toxin is approved for chronic migraine and can be used in older adults. And then remember that I mentioned these devices that can also be used for prevention. A second type of primary headache disorder that can be seen in older individuals are attention type headache. These are usually mild to moderate, never severe. They're never throbbing. People could have a light sensitivity or sound sensitivity, but not both. There's no nausea, no vomiting, and sometimes it gets better with activity. And about a third of the people who get tension type headaches are older than 55. And the treatment of attention type headache is similar to when people who are not older. And that is acute treatment can be acetaminophen, a nonsteroidal, but remember we have to watch the stomach, and some of the devices. Preventative treatments are mainstay for prevention in tension type headache has been a tricyclic antidepressant. But in older individuals, we have to use caution. Sometimes people use mirtazapine or doxepin. which seems to be a little bit better tolerated as somebody gets older. Then we have venlafaxine, which is a SNRI, tizanidine, which is a muscle relaxant, and then topiramate and low doses of gabapentin. And then our non-pharmacologic treatments like devices, biofeedback, transcutaneous nerve stimulators may be helpful in tension-type headache as well. Now, cluster headache occurs more frequently in men, and you can see from this chart here, it usually starts in early adulthood, and then it does seem to get better with age as well. You can see after 60 or 70, it seems to slow down, but it can still occur. And it's a peculiar headache because it doesn't last that long, but it's extremely severe. It's always on one side. It has lacrimation, rhinorrhea, flushing, the nose runs, and you can see in this individual, this woman is tearing because tearing is frequently there. It's extremely severe. Sometimes it's called the suicide headache. So you can, as people get older, we can treat that as well with many medications. The medications that we like to try for, let's say, paroxysmal or cluster headache are things like galcanezumab, which can be used in an older adult, and verapamil. Paroxysmal hemicrania is much shorter, 2 to 10 minutes, and we usually use indomethacin, but this is, again, a non-steroidal anti-inflammatory, and you have to use caution. Some people use low doses of melatonin for this headache or topiramate, but again, you have to use caution. Hemicrania continua is a continuous headache on one side with episodes of bursts of pain in its response to indomethacin, but there are these caveats of warning. Then we have this problem. This is an 81-year-old man who's been on Excedrin for 30 or more years, daily Excedrin, and he's had a severe headache, no nausea. And we talked to him, we said, I think you've got a tension-type headache, but you've also got medication overuse headache. He stopped his Excedrin, and his headache actually resolved. So medication overuse headache is common in older individuals, especially in medications that have caffeine in them. So they could have acetaminophen, which is like Tylenol, aspirin, and caffeine. And if you overuse analgesics more than about 10 to 12 days each month, then you're in danger of getting medication overuse. Triptans, 10 days a month, non-steroidals, sometimes more than 15 days a month. So medication overuse headache is a headache type that you have to be aware of. I'm going to switch gear to this 84-year-old physician. He has a family history of migraine, and he's had migraine with aura since his 20s. And then in his 40s, he stopped getting the headache, and he just gets the aura. And his aura is a typical zigzag line that goes off to the right side. And when it does go off to the right side, he notices sometimes his speech is garbled, and he might have some weakness. And this is called migraine aura without headache. It's a typical aura, but no headache follows. And it's typically seen as people get older. So it's sometimes called late life or late onset migraine accompaniments, popularized by C. Miller Fisher. And it sometimes doesn't decrease with age, but it usually starts after age 40. And the main thing is you have to differentiate this from what we call a transient ischemic attack, which in an older individual can signal that you're going to have a stroke. So it's really important to tell the difference between an aura and a TIA. So in migraine auras, it's usually positive, and it's usually slow moving. It lasts 5 to 60 minutes and it goes away. There's a gradual buildup. And sometimes you can get tingling and around the hand and the face, especially around the mouth, and it's called chiroaural. Versus a transient ischemic attack is, boom, sudden loss of vision, unilateral, bad at the onset, abrupt onset, and then numbness, and then paresis, meaning weakness, and then the simultaneous onset of weakness and sensory loss, and it's not stereotypic. So really important to distinguish aura from a transient ischemic attack. The other reason aura is important is that we are now finding out that migraine with aura has an increased risk of cardiovascular disease. So migraine with aura is associated with increased risk of disease, even more than obesity and an unfavorable lipid profile. And then if you smoke and have aura, that's even worse. And then if you add diabetes to the mix, it's even worse. And so you have to be aware that aura can increase your risk of cardiovascular disease, and you want to control underlying risk factors. Talk to your provider about controlling for cardiovascular risk factors. All right, I'm going to go to one other primary headache disorder. This is an 80-year-old woman. She has a family history of migraine in her mother. And she had previous migraine, but they went away in her late 50s. And now, about 3 years ago, she started getting a kind of a right-sided headache. Pain goes down to her ear and her shoulder. She has no light and sound sensitivity. And she usually gets the headache at night. And it wakes her up at 2 in the morning or at 4 in the morning. And if she takes a nap, she can also get a headache during the nap. And this is called a hypnic headache or alarm clock headache. And it is a headache that develops during sleep and causes people to wake up. And it doesn't last usually 15 minutes to 4 hours, but it can occur frequently. It's seen more frequently in women than men, and it's in older individuals. So in the 60s is about when people start to develop hypnic headache, and it's been reported up to people in their 80s. Moderate to severe pain, and it can be unilateral or bilateral. There's rarely nausea. And you can treat it. So what's interesting about this headache, for prevention, you could take a cup of caffeinated beverage, like 1 cup of strong coffee or a caffeinated beverage before you go to bed, and it can completely eliminate this headache. Other preventives are like lithium, but that has many side effects in an older individual. Indomethacin, remember, can cause stomach trouble. Tricyclics can cause memory problems. Topiramate can have side effects. And then acutely, if the headache is going on, caffeine or aspirin with caffeine or caffeine analgesics are very successful. Triptans work a little bit, nonsteroidals work, and even oxygen can work. So in anybody who has headaches and primary headache disorder in older adults, I want you to consider 2 things. One is depression. If your score is over 3, you want to talk to your provider. And the 2 questions are, do you have little interest in pleasure in doing things? Not at all, several days, more than half the days, nearly every day. And you get to a point, you can see how you get 0 points at not at all. Several days are 1 point. More than half the days are 2, and nearly every day is 3. The other question is feeling down, depressed, or hopeless. And then you tally up your score. And if you have a score over 3, you should really talk to your provider, because as people get older, their brain is more susceptible to depression. And if you've got headache and depression, of course, that can be a really difficult combination. The second thing you have to be aware of is sleep apnea, which is more common as people get older. Often the headache is in the morning, and there's this screening tool for that. It's called Stop Bang, and the S is for loud snoring, tired during the day, observed apneic, meaning you quit breathing, spells, hypertension or high blood pressure, a BMI of over 35, so you have to know your weight and your height, an age over 50, a neck circumference that's bigger than 41 centimeters for female, 43 for male, and a gender, which is usually men. And if you have a positive, so each one of these would give you a point, and if you have 3 to 4 criteria positive, you've got intermediate risk. If you've got 5 to 8, you've got high risk. So you would want to talk to your provider about getting tested for sleep apnea, because that can cause headaches all by itself. The other final word about primary headache disorder is that there are a lot of comorbidities that come with people with migraine. I already mentioned that migraine aura is associated with cardiovascular disease. Hypertension can complicate migraine. Thyroid disease can frequently go along with migraine. Hypothyroid, hyperthyroid, thyroid nodules, kidney disease, gastrointestinal disease like diarrhea, ulcers, irritable bowel syndrome, and cervical spine disease. And I'll show you some secondary headaches of the cervical spine. So we're going to go away now from primary headache disorders. These are headaches that come just because you've got migraine, tension type headache, cluster, hypnic headache, something like that. They can be treated, but we have to use caution as we treat them, and so on. Secondary headaches, however, are important for older individuals because a secondary headache is 10 times more likely to be diagnosed in somebody over 65 with a new headache. And if you look at somebody who has a sudden onset of headache and they're over 50, they've got an over 50% chance of it being a hemorrhage in the brain. And then strokes can be associated with headache about 25 to 30%. So headache in an older individual who's never had headaches before, or it's a change in your headache, you want to talk to your provider because there can be many causes. And there are some ways that we can look for secondary headaches, like does somebody have systemic symptoms, like have they had fever or weight loss? Do they have a systemic illness like cancer, or they're immune compromised, or they're on prednisone, for example? Do they have neurologic symptoms or signs? Is the onset less than a minute? Are they older, age over 50? Do they have a new headache or progressive headache? Is the headache postural? Is it precipitated by exertion or valsalva, like the bearing down like you have a bowel movement? Is there pulsatile tinnitus? Are there visual obscurations? And of course, we don't have to worry about pregnancy in this age group usually. So here's a secondary headache. So this is a 65-year-old man, and he had new vision changes. He has a history of migraine. He had migraine with aura about once every couple months. And they used to be more frequent when he was younger and when he had a more stressful job, and they got less frequent. But over the last month, he's been having episodes of coloring spots in his field lasting 30 seconds to 3 minutes. And they look like pinwheels. There's kind of a rotatory portion to it, and his neuro exam appears normal. However, he had an MRI scan, and he had a right occipital lobe tumor that was diagnosed as a ganglioglioma. And he had EEG that showed seizure activity in his cortex. And on this MRI scan, you can see this mass in the occipital lobe. Aura can kind of mimic seizure, and seizure can mimic aura, but seizures are usually abrupt in onset versus auras, which are gradual. They last much shorter, like 1 to 3 minutes, and they can be very, very frequent. And they often have this movement to it, and rapid movement. And seizures visual seizures are pretty uncommon. Most seizures are motor seizures. Here's another case. This is a 78-year-old retired physician, and he has never had headaches before. He developed a new headache with visual loss, double vision, and mental status changes. And we did an imaging on him, and his CAT scan showed a hemorrhage in his pituitary gland, which is right here where my arrow is. And you can see it here also on this coronal CT scan and on this sagittal CT scan. So he had a pituitary tumor that he didn't know he had, and it hemorrhaged into it. And that's where I said that was sudden onset of headache. And if you're over 50, think about a hemorrhage. So vascular disorders are a little bit more common in older adults. Strokes can present with a sudden onset of weakness, numbness, and speech problems, and headache can occur in 1/4 to 1/3 of these people. And there can be many, many causes like carotid dissection, a sudden hemorrhage that can cause a thunderclap headache from an aneurysm, a hemorrhage from amyloid angiopathy, which is a specific blood vessel disease seen in older individuals. And then, as we discussed, individuals can have cardiovascular risk factors with higher incidence of depression, sleep disorder, insomnia, and then a subdural hemorrhage. Now, subdural hemorrhages often occur in older people because there's a little bit of extra space up here. And let's say you have a quick fall, hit your heads, and you don't think anything, and then you have trouble walking, And this is way more likely to occur in an older person, and the headaches don't have to be severe. Okay, here's another problem. This is a 75-year-old woman who had a history of migraine for years, but they all went away. But now she has a new daily persistent headache, and her primary care doctor did an MRI scan. However, uh, about a week or two later, she lost vision in her left eye. She became blind in her left eye, and she has what's called giant cell arteritis or temporal arteries. And this is always seen in individuals who are over 60 or 70. The pain is usually bitemporal with some scalp tenderness, and the SED rate can be elevated. The C-reactive protein can be elevated. And then they have symptoms of aching in their shoulders, their hips, some weight loss, anemia. They often have another symptom called jaw claudication, like pain when you chew your food, and it can cause blindness. So it's really important to get this diagnosed. And if you have those symptoms, you want to tell your provider. A very common cause of headache in older individuals is shingles or post-herpetic neuralgia. This is an older man over 50 who had acute onset of a left-sided headache, and then he had these little kind of scabby lesions that occurred on the left forehead, and very painful itching, and then 3 months later he still had pain and itching, and that's called post-herpetic neuralgia, and it can be associated with depression. And what's amazing about this is you can prevent yourself from getting this by getting your vaccination against the herpes zoster virus. So it's a Shingrix vaccine, and you can prevent ever having from shingles on your face or on your body with that vaccine. And then another very rare but deadly headache is called cardiac cephalgia. And this is almost only seen in people who are over 65. And it's a headache that comes with heart ischemia. So imagine everybody thinks that you're going to get chest pain, crushing chest pain. Well, some people, instead of getting chest pain, the pain goes into their head with exertion, and then it goes away with rest. So it's a very rare cause of a headache, but it's one that older people should be aware of. Now, this is another cause of pain. This is a 70-year-old woman who had pain in the back of her head radiating to her eye, and she has a chronic headache. And what we found on her is she, at the top of her cervical spine, so this is a cut down the middle, and this is the brainstem, the cerebellum, the spinal cord. This is her tongue. So her face is over here. But what we're seeing is we've got this great big mass at the top of her cervical spine called the dens, and it's a deposit of calcium, and it can lead to head pain that can radiate to the eye. It's often seen with rheumatoid arthritis. There's not a lot of good treatments for it, sometimes steroids, sometimes occipital nerve injections can be helpful. But rheumatoid arthritis can be more common as people get older too. It affects about 1% of the general population. It often involves small joints. And as you can see, it gives you somewhat of these little deformities of the hand. And it affects women more than men. And it causes chronic inflammation. And then you get that thickening at the top of the dens. And you can see that this causes sort of, this is another case, not only does the dens push up, but it also kind of compresses the upper cervical spine, and it causes headache, and it can cause other problems as well. So it's another cause of a daily headache, especially in the back of the head. And then trigeminal neuralgia. It's the most common neuralgia after 50, and it occurs in three places. One, the pain right by your nose, one by your eye, and one on your chin, okay? And the pain is very peculiar. It's frequent short bursts of pain in the trigeminal distribution up at the top, the cheek, or the chin, and frequently brought on by, let's say, if you brushed your hair, oh my goodness, it would set it off, or you're chewing your food, or you're brushing your teeth. And you can see on this little graph here, the staccato-like pattern of trigeminal neuralgia over seconds, and it's extremely painful. And the most common cause in an older person is a vascular loop pushing on the trigeminal nerve. And so we frequently will do imaging, either CT with contrast or an MR, a special kind of MR. In younger individuals who get trigeminal neuralgia, we think about multiple sclerosis. So I've gone through some of the primary headache disorders and what happens when people get older. Usually migraine gets better. There are certain medications we use for acute headaches and prevention in migraine. And then there's a whole list of secondary headaches that are more common as people get older that people should be aware of if you have a new headache and you're older. We have many resources for you. You're listening to Headache School today, and we have many lectures, hundreds of lectures here for you. They're short, and they're all free. We have a downloadable patient guide that you can download from our website. We also have a dizzy school because migraine can often be associated with dizziness, and you can go to our dizzy school for free as well. And then the American Migraine Foundation has many really great resources for individuals with migraine at any age.